Health equity impacts health outcomes. Existing disparities contribute to the rising rates of maternal morbidity and mortality. Welcome to Advancing Health, a podcast from the American Hospital Association. I'm Tom Petterly, senior writer with AHA. In this podcast, Priya Bathija, Vice President of Strategic Initiatives at the AHA, speaks with Dr. Jonathan Weeks, a maternal-fetal medicine physician and the medical director of the MOST program at Norton Healthcare. Joining them is Charlotte Ipsan, Chief Administrative Officer for Norton Women's and Children's Hospital. And now to Priya.
Thanks, Tom.
Hello, I'm Priya Bathija, Vice President of Strategic Initiatives at the AHA, leading our maternal and child health efforts, including our Better Health for Mothers and Babies initiative. This podcast series is part of our maternal and child health program. The AHA is committed to advancing women's and child health through partnerships and innovation in the quality, cost, and delivery of care. This includes a focus on reducing maternal morbidity and mortality through 4 key areas: analyzing and acting on data, examining disparities, engaging mothers and their families, and partnering with community resources. In this Members in Action podcast, we welcome Norton Healthcare from Louisville, Kentucky. Norton's Maternal Opiate and Substance Treatment, or MOST program, offers addiction treatment for pregnant women with a substance abuse disorder. Joining me to talk about this program is Dr. Jonathan Weeks, a physician and medical director for Norton Healthcare's maternal-fetal medicine program, as well as the MOST program, and Charlotte Ipsan, who is the Chief Administrative Officer of Norton Women's and Children's Hospital. Dr. Weeks and Charlotte, thank you for joining us today.
Thank you.
Thank you.
Norton Healthcare has implemented a number of programs to improve maternal and child health. Dr. Weeks, can you share a little bit about Norton's Maternal Opiate and Substance Treatment Program, which is also known as the MOST program?
I'd be happy to. The program started in July of 2015. By then, the prescription pain pill addiction epidemic and heroin epidemic was well underway. It had been for a number of years. We were seeing a growing number of young pregnant women who were affected by substance use disorders, and there was a real reluctance to take them in and to get them started on treatment. When we started our program, this was kind of well ahead of the rest of the nation's coming to grip with the program and understanding it as a mental health disorder rather than just a behavioral disorder.
How has the MOST program impacted maternal and child health for the community you're serving?
I'd say the biggest way that it's helped, and Charlotte can probably help here, is we did a number of things. First, we made it easy for patients to access care. So within our program, when we started the program, I was already board certified in addiction medicine and had a waiver to prescribe Subutex and Suboxone. So we decided to have patients admitted to the hospital, evaluated in the office, begin talking to them about the types of behavioral health programs they needed to enter while we were prescribing medications. What that did was get the patients out of a cycle of traveling to different ERs for temporary help or inventing diagnoses to get medications. They actually were able to come in to care. And the next thing that happened was our ability to screen the patients, get them actually stabilized on medications, and do an obstetrical evaluation. It was much easier for them to then access prenatal care and addiction medicine care. When we started, addiction medicine doctors would say, I'm not going to take care of you until you get obstetrical care. Obstetrical doctors would say, I'm not going to take care of you until you get addiction medicine care. And the patient was stuck in a vicious cycle. And these are people who have a decreased capacity to sort of endure frustration or even the means to make all those different visits. That was number one. The second benefit to the community is we set an example for many other providers and hospitals. We showed that a team of physicians, nurses, nurse practitioners, MAs whose expertise is in obstetrics can enter into the substance use disorder arena and make a positive impact. There were physicians, nurses who saw dramatic changes within their patients, just brought about by the few steps we initiated, and so they became a bit more open-minded to taking on some of the patients with a substance use disorder. And finally, several other surrounding hospitals heard about our program, the impact it was having in the NICU, and reached out to us to get training so that they could initiate similar programs in their backyards.
Yeah, and I will share that because of the vision and passion of Dr. Weeks and a team around him, we had to step up and say, we are not a psych facility. We are here to care for the family. And it's okay to integrate these patients that struggle with this disorder in a regular practice. And I think that was one of the key components to the success of the MOST program was Dr. Weeks and that team's willingness to have that patient come into that practice. So they were integrated with normal. They weren't showing up at a clinic that only saw patients with substance use disorders. So the ability for them to take care of the entire patient, and as Dr. Weeks described, the discoordination of care that these patients were seeing was a barrier to them getting help. That's, I think, the biggest impact that we've seen in the community, and those other community resources stepping up to say, hey, we want to be part of this. How can we assist or transition from the facility? Because the inpatient stay was, an average of 2 to 3 days a stay. But because of the design of the program, and obviously Dr. Weeks, used evidence-based medicine and is actually, there's articles out there that he's published that really does talk about what these people need in order to help hold them accountable and to get the outcomes that we were looking for. He mentioned the nursing team, and one of the biggest challenges to me as a former neonatal nurse was the education that was needed for all of the care providers who weren't specifically trained or educated on this disease. And because of the intense education that was provided to these people, we were able to change just the way they cared for patients. They could understand the disease and really help be transparent with the patients and what the behaviors and expectations. And it's a pretty rigorous admission criteria. But if you're going to expend the resources and you want to get the outcomes that we're looking for, that's what we had to do. And that was a hard lesson to learn, I think, in the beginning, just some of the thoughts that are out there. We had to just face it that most nurses, clinicians, caregivers were not educated on the impact that this disease portrays. And I can tell you some of the outcomes. Dr. Weeks mentioned mid-2015 that the program started. Just looking at numbers, by 2018, we had seen 103 admissions. Now, this doesn't account for all of the folks who didn't need admitted and who were in the MOST program, but those that were admitted was 103. The next year, 101 stayed about the same. And for 2020, we're on track annualized to see about 136 patients. Now you say, okay, wait, that's not a whole lot of patients. But of those numbers, the translation for those babies admitted and managed for neonatal abstinence syndrome, we peaked at about 109 babies, and this is just for Norton Women's and Children's alone. We peaked at about 109 babies, and those were babies that required medication, so admission to a specialized area. We have seen a 41% decrease in the number of babies that have needed admission to our NICU and have needed medical treatment for this. That is a huge win for everybody, moms, babies, and families. So if we can make a difference to that many patients and families, those are the successes that we celebrate.
Right. That's a huge impact to decrease the number of babies needing treatment for this by 41% over such a short period of time. And as you were doing this, and I know, Charlotte, you touched a little bit on the lessons you learned about, education for care providers, but what were some of the lessons you learned along the way, or challenging or pleasant surprises you've seen since 2015 when this program took off? And maybe we can start with you, Dr. Weeks.
One of the lessons we sort of learned, serendipity, is because we had our program where we initiated care, initiated some counseling in the hospital and medications, we had a common occurrence of a patient sort of coming in who was anxious and disagreeable, disheveled, sort of difficult to manage, to leaving very grateful. They kind of shed the guilt and shame they now see light at the end of the tunnel where they actually can get bona fide care, and there is a path to becoming the mother they want to be. That transformation within the first couple of days within the hospital and what those patients look like when they get to the office actually had a profound impact on all of the care providers, because most providers only have an experience seeing these patients when they roll in the ER or they're in the hospital having concealed their addiction and suddenly they're in acute withdrawal where they're anxious, disagreeable, and difficult to deal with. And you can get the impression that that's all they are. This actually gave the patients an opportunity to show, once you actually start treating their disease, they are much easier to deal with. They're as pleasant and as agreeable as most of the patients that we see in our office. So that's one unexpected benefit. The other things that we always knew, there are layers of disadvantage and disability. So the substance use disorder and the medical part is one thing. Often there's psychological or psychiatric scarring. There's the partners and sort of their problems. There's homelessness. And we actually learned to better utilize community resources for getting these patients plugged in. And Norton Healthcare really stepped up to provide additional in-house resources that really pay dividends. So we have a licensed clinical social worker, one initially, and now we have two, who actually can start individual counseling. We've started on-site group counseling because as we were dispensing medicines, the expectation is the patient does something for behavioral health. We started saying go to meetings or referring to different resources, but there wasn't an easy way to hold them accountable. Now, with the ability to do groups by Zoom or in person when COVID's not around and get individual counseling, we can see a much greater progress in their recovery because the ones that enroll relatively early in the pregnancy have months of contact with us. It's just an opportunity for the patient to grow much more in their recovery and for us as providers to become a bit more competent in dealing with them.
And Dr. Weeks, I think another thing that we learned along the way, we had the opportunity to share with Senator McConnell, quite honestly. Dr. Weeks had the opportunity to speak to him directly around things that we could change. We were not able to provide reversible contraceptive in the facility. There was a payment issue, and to say if we can prevent an unwanted pregnancy with these folks during their recovery, we're much more likely to have a successful course. And Dr. Weeks, I don't know if you have anything else to add around that, but I think that was something key that was an intervention that we persisted with, and because of the notoriety of this program, I think we were able to move the needle there.
Yeah, that's an excellent point. So yes, the long-acting reversible contraception, the third-party payers were insisting that it not be placed while the patient's in the hospital. You wait for them to return in 3 months, 6 months later. Some of them will disappear, and they won't get contraception. Often, even the patients who are, let's say, they're not pregnant, they're non-pregnant women, and they're going to a methadone center or Suboxone clinic, they assume that they're infertile because they haven't easily conceived. They've not been using protection. Well, when you're in the midst of a substance use disorder, the changes in brain dopamine, pulsatile dopamine, will cause decreased ovulation. When you enter treatment, ovulation starts happening much more regularly, and patients will unexpectedly become pregnant. Having a small baby while you're trying to get housing, go to meetings, and come to grips with some of the medical and psychiatric problems that you have makes it difficult. So yes, we really stress contraception, and a lesson learned early on was we were failing because we were trying to do it all when they came back as outpatients or when they went back to their original OBs and family practice physicians. And we did make an adjustment where we emphasize as much as possible getting it done before they leave the hospital.
I'll also add that some of the kind of ahas, and maybe most people wouldn't be surprised by this, but we really looked at admissions by referral sources, and I talked a little bit about strict criteria. So we know it's there because we want this to be for patients who indeed want help. And of those, there's a high percentage that are referred by drug and alcohol agencies, but those do not typically lend to be the ones that are actually admitted. Those that are actually admitted are those that came from true physician referrals. So it was very important, and we learned throughout the process to really get to, again, those physicians that may be coming in contact. What about an ER physician? What about the OBGYNs? What about family practice? And those primary cares, ICCs, places like that. That was pretty important, that the admission referral source by physicians was more likely to result in a patient that actually got admitted versus referrals from drug and alcohol agencies. And then we, for whatever reason, see our highest peaks typically in admissions in summer months. It's historically July, and then it starts, there's some issues around December as well. But that was interesting because the first year you're like, okay, it's a blip. Second year, okay, it's a blip. Third year, like, wow, wonder what this pattern is. Those were just some kind of aha. If someone was actually starting a program, I would point out those things to them. And one of those things that we're not that excited about, but that's real, and it was helpful to the staff to say, despite the very strict admission criteria and despite the many conversations that occur with these patients, that about 15 to 20% of them are going to leave AMA. Just dealing with that, is there something else I could have done? Those typically, the caregiver wanting to make sure they're doing everything they can. It's something that we see in this population, and we've not really tackled that yet.
Yeah, that's all really interesting, and it's so fascinating to hear you talk about how this program has evolved and your knowledge around how to best run it has evolved over time. What comes next for this program? How do you see it growing or evolving, or maybe morphing into a new initiative or tying to other work that you're doing at Norton Healthcare?
Well, I'll let Dr. Weeks take that, because I know if we win the lottery, he's got a lot of great ideas around it.
So, yes, our passion, really, many, many years ago when I got a first interest in this, I was in a setting where a lot of healthcare providers were sort of disgusted by this heroin-using mother who's 28 weeks and in preterm labor and not getting care. And one of my first thoughts was, well, the baby's completely innocent no matter what we think. And if we don't do something, this child, we're talking 80 years of potential life at least, that can be a terrible life. And what can we do to break the cycle? Even though patients have substance use disorders, they really do have strong maternal instincts. And if you give them some sort of a lifeline, they'll grab on. What we've learned is you've got significant others who are out there who we don't really have a program for. We can make referrals, but in the end, long-term vision, I'd like to create a situation where we can get the fathers of the babies in treatment when they need it, so that we can have moms and dads being treated during the pregnancy, and for a year or 2 years after pregnancy, in tandem, they're in the same healthcare, behavioral health system together, so it's much easier to monitor both of them and look at accountability with regard to meetings and the behavioral health piece. And also, their baby can be in our healthcare setting where we've got experts who can look at early childhood development and proper interventions. solve the contraception problem and also treat their hepatitis C, because the hepatitis C, we can't treat it during the pregnancy. Most infectious disease physicians and hepatologists will begin treating 6 to 8 weeks after delivery. And for a lot of patients, it's just hard to keep tabs on them. If we can bring all of that together in a single healthcare family, even if we're not in the same campus, I think that can make a big difference.
Well, Dr. Weeks and Charlotte, I truly hope you win the lottery so that all of that can become a reality. Thank you both so much for joining us today and for sharing more information about this important program. This concludes our discussion today. Thank you to all our listeners for listening.